A very warm welcome to all our viewers online for the Ifso Journal Club of July 2023. As you already know, the Communications Committee of the Ifso selects what is in our eyes an interesting study that has been published recently in obesity surgery. My name is Dr. Edo Arts and I'm a bariatric surgeon from the Netherlands. And today we are going into depth on OHGB and Roux-en-Y gastric bypass surgery. It's good to know that this webinar will be recorded, so you can watch it once more on the Ifso Virtual Academy and on our YouTube channel afterwards. I'm very happy to introduce Dr. Mohammed Yacoub. He's an upper GI and bariatric surgery from the Qasr Al Aini School of Medicine, Cairo University in Egypt. And on behalf of his research group, he is going to present on his article published in May in obesity surgery entitled Long Biliopancreatic Limb Roux-en-Y Gastric Bypass versus one anastomosis gastric bypass, a randomized controlled study. Now, during the presentation and afterwards, you as audience can ask questions to Dr. Yacoub directly. So don't hold your horses and ask away by typing in the question and answer box on the bottom of the Zoom session you are in. So let's start the presentation.
Good afternoon from Cairo, Egypt. Thank you for this invitation to participate in this webinar. It's my honor to take this chance to talk about this interesting subject, the long biliopancreatic limb Roux-en-Y gastric bypass versus one anastomosis gastric bypass, a randomized control study. I am Mohammed Yacoub, consultant and lecturer of laparoscopic upper GI and bariatric surgery, Qasr Al Aini School of Medicine, Faculty of Medicine, Cairo University, Egypt, a member of Royal College of Surgeons of England. Actually, this work was only completed by this great team in my general surgery department in Qasr Al Aini School of Medicine. Professor Dr. George Abdelfadi, Professor Dr. Ahmad Abdallah, Professor Dr. Ahmad Abdesalam, Professor Muhammad Salman, and me. As we know, obesity prevalence has been persistently increasing, and bariatric surgery is the most effective long-term management strategy for the morbid obesity. For the past 20 years, Roux-en-Y gastric bypass has been the gold standard in bariatric surgery, and it is the second most frequently performed technique, of course, after the laparoscopic sleeve gastrectomy. This success has been attributed to its consistently achieving long-term weight loss, resolution of comorbidities, and acceptable mortality rates. The one anastomosis gastric bypass procedure features one anastomosis instead of two, resulting in technical simplicity, shorter healing times, and a lower incidence of early post-operative complications. Additionally, the one anastomosis gastric bypass is simpler to modify or reverse. Compared to the standard Roux-en-Y gastric bypass, one anastomosis gastric bypass has shown about 25% greater weight loss efficiency, which is attributed to the malabsorptive impact of the substantially longer biliopancreatic limb or the afferent limb. Of course, biliary reflux is the most crucial complication following the one anastomosis gastric bypass, and it should be properly treated to prevent further damage and Barrett's esophagus to the esophageal mucosa. Due to this complication, many surgeons avoid one anastomosis gastric bypass as an option for the bariatric surgery. The percentage of excess weight loss after Roux-en-Y gastric bypass is 40 to 70% after a 5-year follow-up. However, about 10% to 40% of patients experience inadequate weight loss with persistence or recurrence of comorbidities after 5 to 7 years. Endoscopic rather than surgical approach is preferred in restrictive revision because of less invasive nature with similar outcomes. However, the percentage of excess weight loss after endoscopic solutions is usually unsatisfactory for the patients who underwent Roux-en-Y gastric bypass in the first place. In fact, the idea for elongation of the biliopancreatic limb in Roux-en-Y gastric bypass came from the efficacy of limb distalization in Roux-en-Y gastric bypass as a revisional surgery. So the revisional malabsorptive procedures included duodenal switch with biliopancreatic diversion and the limb distalization. Biliopancreatic, the duodenal switch with biliopancreatic diversion after Roux-en-Y gastric bypass was associated with satisfactory excess weight loss percentage. However, the conversion to duodenal switch with biliopancreatic diversion is a demanding procedure and associated with protein energy malnutrition after the failed primary procedure, the Roux-en-Y gastric bypass. So the limb distalization is the most frequent malabsorptive revision for inadequate weight loss after Roux-en-Y gastric bypass. A recent meta-analysis showed that the shorter alimentary limbs are as effective for weight loss as longer ones. Therefore, we thought an alimentary limb length of 75 cm was reasonable, and the elongation of biliopancreatic limb in Roux-en-Y gastric bypass has been linked to more considerable excess weight loss, but similar post-operative morbidity. A meta-analysis done by Hamid et al. Discussed type, safety, and efficacy of limb distalization for inadequate weight loss after Roux-en-Y gastric bypass. Proposed a more comprehensive sample classification for different types of and techniques of limb distalization. This classification included 4 types of limb distalization: type 1 for biliopancreatic limb distalization, type 2 for Roux or alimentary limb distalization, type 3 for both limbs, and type 4 when done for or after a long biliopancreatic limb Roux-en-Y gastric bypass or after a long Roux-en-Y gastric bypass. As we can see in this diagram, this is a revisional surgery for the Roux-en-Y gastric bypass by elongation of the biliopancreatic limb after division of the Roux limb and reconstruction by single anastomosis to create a jejunostomy after elongation of the biliopancreatic limb. Actually, the aim of this study is to compare the outcomes of the one anastomosis gastric bypass and the long biliopancreatic limb Roux-en-Y gastric bypass regarding the weight loss and comorbidity resolution, such as hypertension, type 2 diabetes mellitus, obstructive sleep apnea, and joint and back pain. In our study, 62 patients were randomly allocated to 2 groups. Group A underwent long biliopancreatic limb Roux-en-Y gastric bypass, and Group B underwent one anastomosis gastric bypass. The randomization procedure was performed using the closed envelope method. Adults with a BMI of 40 kg per meter square or more, or 35 kg per meter square or more with comorbidities were suitable candidates for our study, provided that they tried non-surgical treatment options without success for at least 6 months. Patients who were candidates for Roux-en-Y gastric bypass or one anastomosis gastric bypass fit for surgery and accepted to participate were included. All patients underwent the preoperative workup, including complete medical history, clinical evaluation, routine laboratory investigations, and abdominal ultrasound. Patients with previous bariatric surgery, congenital inflammatory hemorrhagic GIT diseases, hiatus hernia, immunodeficiency, or autoimmune connective tissue disorders, or neurological and mental conditions were excluded from our study. Informed written consent was obtained from each patient before participation. Regarding the obstructive sleep apnea, all patients were asked to complete the Stop Bang Score questionnaire, which was developed for a concise obstructive sleep apnea screening. It entailed 8 questions assessing snoring, tiredness, observed apnea, high blood pressure, BMI, age, neck circumference, and the male gender. For each question, the patient scores 1 or 0 for yes or no answers, respectively. Therefore, the total score ranges from 0 to 8. The questionnaire has a high sensitivity, using a cutoff score of 3 or more to diagnose obstructive sleep apnea. As we can see in this diagram, our randomized control study included 62 patients equally allocated to one anastomosis gastric bypass group or the long biliopancreatic limb Roux-en-Y gastric bypass group. All patients completed the study without dropout. The age ranged from 19 to 59 years with a mean of 36 years in both groups. Female constituted about 2/3 of the patients and participants. Both groups were comparable regarding the age and sex. Regarding the baseline patients' characteristics, there was no significant difference between the two groups regarding the baseline BMI or the excess body weight. At the baseline, diabetes mellitus was significantly higher in the long biliopancreatic limb Roux-en-Y gastric bypass group than in the one anastomosis gastric bypass group. No significant difference were reported regarding hypertension or the low back pain or the stop bang score baseline. Regarding the operative technique or the operative procedure for the one anastomosis gastric bypass group, the gastric pouch was created after identifying the ligament of Treitz with a biliopancreatic limb length of 200 centimeter. With a vertical or slightly oblique omega loop, isoperistaltic side to side 30 millimeter gastrojejunostomy. In the Roux-en-Y gastric bypass group, an anti-colic, anti-gastric Roux-en-Y gastric bypass procedure was performed laparoscopically in all patients with 150 centimeter biliopancreatic limb that was anastomosed side to side with the gastric pouch in anti-colic fashion. Also a 30 millimeter gastrojejunostomy was performed. Along the mesenteric border, the alimentary limb was 75 centimeter long with enterostomy with the biliopancreatic limb was performed. Therefore, 225 centimeter of the small intestine was excluded. After that, methylene blue test was used to check any anastomotic leak in both groups. Regarding the Roux-en-Y or long biliopancreatic limb Roux-en-Y gastric bypass group, we closed the Peterson space and the jejunostomy space using non-absorbable braided sutures to avoid any possibility for the internal hernias. In some circumstances, a tube drain was inserted. In the post-operative care and follow-up, patients were encouraged to mobilize early following surgery and the routine post-operative care was performed. Patients were scheduled for follow-up 1 week, 1 month, 3 months, and 6 months after the surgery, during which they underwent a complete clinical examination. Excess body weight and excess body weight loss were calculated. Comorbidity resolution was evaluated according to the standardized outcome reporting of the American Society for Metabolic and Bariatric Surgery. Remission of type 2 diabetes mellitus and hypertension was considered if the patient discontinued all the medications with normal fasting glucose level and normal hemoglobin A1C and normal blood pressure, respectively. Improvement of hypertension or type 2 diabetes mellitus was defined as reduction of the dosage of one or more medications, but not necessarily all medications. Obstructive sleep apnea remission was considered if the stop bang score was 2 or less. At 6 months post-operatively, the BMI ranged from 26 to 51 kilogram per meter square, with a mean of 36 kilogram per meter square in the one anastomosis gastric bypass group, while in the long biliopancreatic limb Roux-en-Y gastric bypass group, it ranged from 26 to 48 kilogram per meter square, with a mean of 38 kilogram per meter square. The excess body weight loss percentage in the long biliopancreatic limb Roux-en-Y gastric bypass group ranged from 22 to 94%, with a mean of 54%, while in the one anastomosis gastric bypass group it ranged from 26 to 90%, with a mean of 49%. There was no significant difference between the two groups regarding the postoperative BMI or the excess body weight loss. Concerning the comorbidities, remission was evident in all diabetic patients in both groups, and significant improvement and complete resolution occurred in 39% and 61% respectively of the one anastomosis gastric bypass group, compared to 27% and 72% respectively of the long biliopancreatic limb Roux-en-Y gastric bypass group, with no significant difference between both groups. Similarly, all patients with hypertension showed postoperative remission with no significant difference between both groups. Regarding obstructive sleep apnea risk, significant improvement occurred in all patients of the one anastomosis gastric bypass group and the long biliopancreatic limb Roux-en-Y gastric bypass group, with no significant difference. Additionally, all patients with low back pain demonstrated postoperative remission in both groups with no significant difference. However, about 1/4 of the one anastomosis gastric bypass group experienced reflux symptoms, while no reflux symptoms were reported in the long biliopancreatic limb Roux-en-Y gastric bypass groups. These symptoms were controlled by proton pump inhibitors, and there were no major complications or mortality encountered during the follow-up. In fact, the small size and short-term follow-up are possible limitations of our study. Nevertheless, our work provides a new evidence regarding the comparability of one anastomosis gastric bypass and the long biliopancreatic limb Roux-en-Y gastric bypass in weight loss and comorbidity remission. We recommend further post-operative studies with a larger series of patients for a longer follow-up duration. Actually, extending the biliopancreatic limb and Roux-en-Y gastric bypass provides weight loss and comorbidity remission comparable to that of the one anastomosis gastric bypass. Some one anastomosis gastric bypass related reflux cases remain a concern. However, they were sufficiently controlled with PPIs. Due to one anastomosis gastric bypass superior technical simplicity, long biliopancreatic limb Roux-en-Y gastric bypass should be an alternative for cases whom are more risky for bireflux. Bireflux is the most crucial complication following surgery, should be treated properly to prevent further damage to the esophageal mucosa. Due to this complication, many surgeons avoid one anastomosis gastric bypass for bariatric surgery. However, in our study, all patients were controlled using PPIs. Further randomized controlled trials with larger samples and longer follow-up are highly recommended. Thank you so much for this chance for me to participate in this marvelous webinar. Thank you.
So, if I'm correct, I'm back on the screen again. So we're gonna have a small minute here for Dr. Yakub to re-enter. Unfortunately, the connection has been lost. I think it is a great representation of what is actually going on right now worldwide in terms of, let's say, the discussion on what to actually use as a primary case. OAGB, of course, done by many surgeons, but not that long compared to Roux-en-Y gastric bypass surgery. And everybody's still wondering about what procedure might suit best. Now, to remind you all once more, if you have any questions to Dr. Yacoub, you can actually ask them in the Q&A box down below there to make sure that we get everything set and ready, and make sure that all your questions are actually answered by Dr. Yacoub. I see that Dr. Yacoub has re-entered the room again. Can you hear me? So unfortunately, I do not hear him. So in my practice, actually, most of the procedures being done are OAGBs, and I had a little concern about the length of the biliary limb that was used in this study. Perhaps it's relatively more common in other parts of, let's say, the world, but we tend to keep it at 150 centimeters. Because of the studies coming, for example, from India, showing more micronutrient deficiencies if you are talking about more limb length. And especially, of course, protein deficiencies are quite relevant when you go over the amount of let's say, length of 150 centimeters. And I think that has to do with the total limb length of a patient in terms of if you have a patient that unfortunately without measuring has a limb length of 3 to 4 meters and you would bypass half of that, then apparently or in general you would suspect more protein deficiencies in the long term. And of course, this study has been done in patients receiving a 200 centimeter biliary limb length and has been only carried out for 6 months. So I think that it is quite important actually to keep measuring these patients in terms of micronutrient impacts in the long term. That is what one of the questions here asking the Q&A is also about. So let's see whether Dr. Yacoub can re-enter again and explain a little bit further, because the nutritional impact. So thank you for the question, Louise. Is actually quite important, because you have to make sure that those patients don't get deficient in the future. We did a couple of RCTs in patients receiving different micronutrient supplements, let's say in Roux-en-Y gastric bypass surgery, and we saw the same cutoff level as well. So if you go over 150 centimeters, you see more, especially ferritin deficiencies in Roux-en-Y gastric bypass patients. And I would suggest, or would think at least, that is the same in OAGB patients. And again, major concern, of course, is things like, indeed, what is the amount of diarrhea in these groups. What I would like to remark in this study as well is that if you look at the not so necessarily the vitamin and mineral deficiencies, but if you look at the amount of numbers required to actually come up with a difference in weight loss in between OAGBs and Roux-en-Ys, especially with these kind of limb length, then rather do you have, and that was one of the limitations of this study as well, a much larger, much longer, let's say, or larger group of patients and a longer follow-up. So Dr. Yacoub, I can now see you again. Can you also hear me?
Yes, I'm here. I'm sorry for this disturbance. Actually, many problems regarding the updates, and after that, the network happened. I'm so sorry for that.
No worries. So let's just start off with the first questions that the audience had, and I think a major one is actually, did you look at nutritional impact? So did you look at albumin levels? And of course, it's only 6 months, but was there a difference in micronutrients like ferritin or B12, or was there any measurements taken?
Actually, we didn't take blood samples for any nutrients, either macro or micro. We just compared regarding the weight loss and the comorbidities control. And this is one of the limitations that may be done in another papers to to find the difference between both procedures, as all we know that one anastomosis gastric bypass has many deficiencies after after doing the surgery. So we did compare between both actually.
Because we already know from literature, of course, that if you go over 150 centimeters of your biliary limb in an OAGB, you can expect more protein and micronutrient deficiency. So what was your reason to choose for those 200 centimeters?
I couldn't understand the question correctly.
Oh, so there's although it's limited, there is literature out there that actually makes us as surgeons aware of the more frequent diagnosis of protein deficiencies and let's say ferritin and B12 deficiencies if you go over 150 centimeters biliary limb in an OAGB. So why did you choose 200 centimeters instead of the 150 that is relatively now more commonly used?
Actually, there was no specific reason for that. We chose to make it 2 meter. Regarding, as you know, some surgeons do it 150 and others 2 meter. There was no specific reason to choose the actual length for the afferent limb.
Right, and so just to make sure that after 1 year or so you do the measurements, your blood work, let's say, to see whether patients have any deficiencies, for example.
Yes, we do it regularly after one year, and after that annually. A list of lab work is done for to check the any deficiencies regarding albumin and zinc and vitamin B12.
Right. So and you advise vitamins and sort of specialized multivitamin and calcium or something for both procedures?
We do it routinely, but we didn't continue to compare between both groups.
No. I mean, is your advice to the patient, let's say, so they had their surgery, is your advice to your patients to take a multivitamin and calcium on a regular basis?
Yes, for good. After the bypass surgery, specifically, we advise the patient to continue their life using multivitamins and other, and sometimes we give them injections.
Right.
Regarding vitamin D and vitamin B12 and vitamin B complex in general.
Okay. One more question that was asked by Luis Valera is was there any diarrhea in the OAGB or in the Roux-en-Y gastric patients?
Yeah, actually, the diarrhea was not one of the primary outcomes that we compared in both groups. So we cannot compare in both groups, but usually after bypass surgeries in both types 1 anastomosis and Roux-en-Y, we face this problem.
Okay. So it's of course an interesting subject because everybody's looking for the golden bullet in the sense that which surgery is the most likely or should be chosen as a primary choice in your clinic, let's say. So if you have a patient, a regular patient with let's say diabetes and has a BMI of 40, what is your preferred procedure in your clinic right now?
Actually, there is no single procedure that fit all patients. You know, when we come to choose a specific procedure, we have to look for many items, and according to these items, we can choose. For example, patients with gastroesophageal reflux disease that is proved by the symptoms and the upper GI endoscopy. For those patients, we do not prefer to do a sleeve gastrectomy, for example. And if we are going to do a bypass surgery, we prefer not to do one anastomosis gastric bypass to avoid biliary reflux as we can.
I can imagine, of course, but let's say the patient doesn't have any reflux. There must be a preferred procedure in your clinic, right? So Most clinics do have a procedure that is, so if you have to choose general patient, no reflux in between the long OAGB 200 centimeters or the long Roux-en-Y gastric bypass, which one would you prefer?
The long Roux-en-Y gastric bypass.
Okay.
There
And
is no contraindications for it.
right. So most of your patients do get the long Roux-en-Y. You call it, by the way, the long Roux-en-Y gastric bypass, but many hospitals in the world already do that for 10 years as a standard, so the 150 centimeters, based on a couple of RCTs in the past. So many people are acquainted to it. And I was wondering, if you look at your study setup, you already mentioned that you would have liked to have more patients. Yeah, you've done 6 months of follow-up, and probably a lot will follow as well. And you were looking especially at what was it, excess body weight loss. That was your primary outcome. How do you come up with the 62 patients? What did you want to look at? Did you want to see the same outcomes, or did you want to see a difference in between the procedures? Where did the 62 patients come from?
The 62 patients, we operated upon them on our institute at Qasr Al Aini University.
Mm-hmm. Oh, I mean the number. Why did you randomize 62 patients? Because it's not in the article. So how did you make your sample size calculation?
Actually, we didn't do the sample size by myself. We take an opinion for statistics specialist in our faculty of medicine.
Mm-hmm. And did
yes.
you want to come up with a difference, or did you want to did you look for similar outcomes? So did you expect to have more weight loss in the OAGB group, or did you expect both to do similar?
Our expectation was it would be a similar outcome regarding this, because the afferent limb and the one gastric bypass and the biliopancreatic limb and the Roux-en-Y are similarly comparable. So we expected that it would be a similar outcome regarding the weight loss.
Now, I saw in your pictures already. You didn't focus on that, but you actually drew how you made the surgeries. Yeah, so the OAGB and the Roux-en-Y. You showed that in the presentation, but you made a long pouch, so an OAGB pouch also in the Roux-en-Y gastric bypass patients. Am I correct?
The pouch of one gastric bypass?
No, they were similar, right? So you drew a long pouch also in the Roux-en-Y gastric bypass patients.
Yes.
Yes. So is that standard in your clinic?
Yes, we try to avoid the micro pouch in general in both either smooth or Roux-en-Y gastric bypass.
Right. So you make a long pouch for also the Roux-en-Y. I do the same. And what it gives me is a very easy gastroenterostomy, of course, because you don't have any traction and pulling.
And sometimes, when you are taking the staple, sometimes misfire happens, and this gives you extra length to go up.
Right. So that's a good option as well. So coming back to that, we also know that the longer you make the pouch, the more ulcers you get. And I know from experience that in Egypt, there's a lot of people still smoking, right?
Yes.
So do you operate first on smoking patients? And second, how many ulcers did you actually see?
Actually, we operated upon all patients, but I have to tell them that they have to stop smoking before the surgery and continue for that after the surgery to avoid any anastomotic ulcer, bleeding, perforation. So I must advise, or I already advised my patients for that. Some patients may stick to the rules, and others, continue smoking. But I have to tell them strictly.
And was there any difference in the amount? Did you see any ulcers, let's say?
In our series, we didn't perform any. We didn't perform. we didn't find any ulcers at this short term for 6 months.
Right, because most of the ulcers that I see in OHGB or Roux-en-Y's, it's around 2 to 4%. They already are there after weeks to months already. So you would have expected to find them if they are there. So that does not seem to be an issue. Now, in the conclusion that you drew, you said some of the patients had bile reflux, and you treated them with PPIs. And of course, with PPIs, you reduce the amount of gastric acid, but you don't treat actual bile excretion. So of course, the amount of volume passing by, it's getting better. But the question is, when do you convert an OHGB to a Roux-en-Y? How many complaints does a patient have to have? Or are you satisfied by people that are going to take PPIs for the rest of their lives? Or should you stop after 5 years? What's your opinion on that? So you have an OHGB with bile reflux. What is your strategy?
First of all, we tried the PPI, and as you said, it actually reduced the HCl. But we found that the patients with symptoms getting better. For how many we use it, there is no specific time. We just controlled the symptoms, and all the patients were controlled. But we may expect after that the symptoms may recur, and we may choose another strategy for treatment up to converting it to Roux-en-Y.
But if we know that if you take PPIs for more than 5 years, the risk of osteoporosis increases quite heavily, especially when patients don't use any calcium. So is that a sort of max in your brain? So 5 years and then we stop, or are you gonna give them PPIs for the rest of their lives, or what is your opinion?
Actually, for our patients, we didn't have to continue for any long period, and it is not an option to make it, as you said, for life or more than 5 years. We don't do that. If the symptoms are persistent, we may convert after confirming the diagnosis. We may convert to Roux-en-Y gastric bypass to avoid this complication.
Okay. Well, we get another question in, and I think it's quite a smart one. I've used it a couple of times, but one of the attendees actually asked, if you have an OHGB with reflux, would a brown anastomosist, so make an anastomos in between the bile, the biliary limb and the common channel, let's say 30-40 centimeters below the gastroenterostomy, reduce the incidence of bile reflux? Would that actually work?
Actually, we didn't try it, but theoretically, it have to reduce the reflux. But I don't think it will work in 100 of the 100%.
I think so. I think you're correct there. I've done it a couple of times, and that was in different cases. But I think that you can't give a clear answer to it because there are so little patients that have undergone that. But in theory, yes, it might reduce it. On the other hand, the biggest issue, of course, is when you lie down at night. So most people have the reflux in a laying position, and I think that probably in many patients a brown anastomosis will be insufficient to 100% reduce it. But it's just theory, because I don't think anybody can give the exact answer. But good question. Good question here.
Yes, a good question. But if we have to reoperate the patient and to treat this bile reflux, so let us do Roux-en-Y. Would be more convenient.
Yeah, so I sometimes also convert from an OHGB to a Roux-en-Y. It's really simple, especially when patients have already lost their weight, and you can actually close the defect very well because you know where you're suturing. Or I sutured with a non-resorbable barbed wire, but you can close the defect very easily. So I think that in theory, also things like internal herniation will not be seen that much after if you do that as a second step.
Yes, so Brown and Smooth, I don't think it is more simple technically. I mean, yani, the surgeon who could do the Brown and Smooth, I think he could do the.
That's it. That's it. Yeah.
Right.
So I wouldn't even think about it, but indeed, the easiest solution is to just do a laparoscopy and convert to a Roux-en-Y.
Yes.
So, of course, you already mentioned 6 months is too little to actually come up with any conclusion. So, and you also said we need studies with bigger numbers, longer follow-up. That's your conclusion. Are you going to do that study for us?
Actually, we have the patients, but yani the last few months we didn't continue to I mean to take the information and to write them down. But in our mind, we aiming or we are planning to continue, inshallah.
Right. So there's a new application to the ethics committee coming, and then you will start again with including more patients. So
yes.
Okay,
yes.
great. So probably more people around the world are thinking about the same. So comparing Roux-en-Y to OAGB. I think that it's not actually the primary surgery in which we're going to see a lot of OAGB, but it's redo surgery, because we're doing a lot of sleeves,
Yes.
and a lot of sleeves have weight regain, unfortunately. What is your opinion? Is an OAGB after a sleeve that shows weight regain, so not reflux? We're not going to talk about reflux. You do a Roux-en-Y then, but if you have a sleeve that has severe weight regain, is an OAGB a good revisional model?
I think if we take the reflux issue out, I think it would be a good option for the redo surgery.
Yeah, I think so too. So for all surgeons, bariatric surgeons around the world, I think it's something to keep in mind, because of course, sleeves can be converted to anything, CDS, Roux-en-Y, OAGB, whatever.
Yes.
But of course, one of the reasons the sleeves is so popular now is because it's a relatively, well, not easy to perform, because it's a good sleeve is hard to perform, but it's relatively short in time. If you think about the surgeons doing that right now, what are they going to choose? The shortest in time secondary surgery, which is always OAGB surgery. That's the easiest, let's say, to re-perform. So I think we're going to see a lot of increase in OAGB surgery, not perhaps in primary, but especially in redo surgery as well.
Yes, but for the patients with I think and it would be a questionable to do it for a patient with a reflux after a sleeve gastrectomy. So it may be for the patient, straightforward patient, it may be a good option. Yes.
Right. Yeah. So is there in the future, what is your, let's say, most extreme biliary limb length that you would find comfortable with? So you're going to 2 meters in an OAGB. Is that also your max that you would go to, or is there something in the back of your mind for perhaps that you say, well, perhaps 250, or measuring the whole limb length, the small intestine limb length, and do a percentage? What is your most extreme idea in that sense? How long can you make the biliary limb, in your opinion?
Actually, for the de novo surgery, the maximum length was 2 meters. For the redo surgery, I prefer to count the length of all bowel, and so we may extend the length, provided that we have to leave at least about 3 meters as a common channel to avoid the severe malnutrition events.
Yeah, I think so too. So the 3 meters a common channel is let's say holy, in my opinion, and even I'm a little bit hesitant to go over 150 centimeters of biliary limb, but that's my opinion, my humble opinion, let's say. So okay. the last remarks from your side. What should we take home as a from you? Of course, you had your conclusion, but is there anything additional that you want to have us take back home as the message that we should incorporate tomorrow for our patients in our clinics?
I think we can say that one anastomosis gastric bypass, for my opinion, I think it is not simpler than the Roux-en-Y gastric bypass. The same thing, the surgeon who can do the one anastomosis can also do the Roux-en-Y gastric bypass. And also, one anastomosis gastric bypass sometimes may be preferred for the good weight loss, excess weight loss after surgery. The Roux-en-Y I think it may give us a good combination between the proper weight loss after the surgery, and also to avoid the biliary reflux with its consequences.
Excellent. Well, thank you so much, Dr. Yacoub, and so sorry for the audience that we had a little bit of a hesitant call in, let's say, but in the end we managed. So Dr. Yacoub, again, thank you so much for your time and effort in elaborating on your interesting study, and I hope that there will be more, let's say, in the future, more patients, longer follow-up. For the last remarks here, the whole interview again will be published because it's been recorded in the upcoming days on the Ifso Virtual Academy and on our YouTube channel as well, for everybody to share with their colleagues or watch it yourself again. So on behalf of Dr. Yacoub and myself, and on behalf of the Ifso, have a great day, and hopefully we'll see you during the next Ifso Journal Club.
Thank you so much, and it's my honor to do a very good meeting like that. Thank you so much. Thank you.
Have a great day. Bye-bye.
And I am sorry for interruptions at first. Thank you.
No worries.